So we're kicking off the medical day, and let's see. Do I advance these slides? How do I do this? This thing? The clicker? The green clicker. Oh, I'm sorry. I'm Dr. Hovland. I'm from Colorado. This is my third year here, and it's really a unique meeting. You guys are the largest group right now today of patients or family members of patients with ocular melanoma, with about 200 people. So give yourself a hand. This is, I found personally, this is a really important meeting as it translates when I go back home to Colorado to meet with my patients in my clinic. Every year I've picked up just really valuable information from this as a clinician. And so I hope you guys find this useful. I'm sure you will. It's a confusing situation oftentimes, and I understand a fair number of you have been diagnosed relatively recently. How many people here are patients who were diagnosed within the last 2 years? Yeah, so at least half of you. So, at any rate, we have a busy day today, so I'll just go through a brief presentation here. Again, just to emphasize that you have a rare condition. Only 2,500 people in the United States approximately will get this condition this year. So, it's considered, anything under 4,000 patients a year is considered, quote, orphan status. And as Dr. Singh mentioned, oftentimes it's overlooked. In fact, you may be the only person you know that has this condition. The melanoma also, the term ocular melanoma is a little broad. So in our own thinking, we separate people into 3 levels of anatomy. How many of you have had an iris melanoma? You're the only one. Maybe one over there. Okay, so it's rare. It's less common. I found in this meeting too, they're less often to be in this meeting. How about this ciliary body? Does anyone know? Okay, just 3 or 4 of you. And then choroidal melanoma? That's everybody else. Okay. So, conjunctival, okay, very good. Any other parts of the body? Okay. So I'm going to talk a little bit about perspectives. I've gone to these meetings, and this is a patient-centered meeting, and most of us physicians, we're used to going to meetings with scientists, doctors, and we tend to talk about genes and things like that. And those are important to know, but I'd like to kind of just for a moment step aside and realize that we're on sort of 2 sides of the fence. The physician doesn't have the disease, but we're offering you advice about it. You guys are experiencing it at a personal level. And I like to think of there's sort of, you can divide it up into 3 parts if you like. That's what I do. A patient, of course, is a unique person. It's a unique condition, unique location. They have unique life circumstances, jobs, family responsibilities, those sort of things. Then there's the support team, the family members, the the employers, church. That's another part of the team in terms of how you cope with this. And finally, the providers. We have two roles. And I think our most important role is to advise you. So communication is really important. And that's, I think, what this meeting is all about, getting information about your condition and sharing it. And then we, of course, provide the treatment, doing the surgery, whatnot. So I'd like to talk about four phases of patient experience. And this is sort of the way I break it down in my clinic. When you first walk in the door, I'm sure you all remember when you first noticed there was a problem, probably maybe at an optometrist, or you totally caught off guard, I'm sure. So I call it the shock and awe phase. It's unexpected and unwelcome. You didn't want this news, and it causes a lot of troubles internally, anxiety. You don't know what's going on. You've got a loss of control. You have to deal with this all of a sudden. You can't ignore it. And fear of the unknown, of course. So that's the really difficult phase, and all of you have been through that. It can persist. I like to think of it as the first couple of weeks, but actually, it can be ongoing longer than that. Then the second phase, I think most people feel like they understand it, they've made their decisions, they grasp, the problem, and they go with the treatment. And at that point, I find most people have, kind of a determination to get through it. And does anyone here have the disease who has not yet been treated? Okay, so everyone here has had some treatment, and Dr. Singh, went through very well the sort of the criteria. I think those are standard criteria that most of us would accept for treatment. And you've probably all had a variety of different treatments. Some of these are used in combination, I might say. The laser might be used in addition to other treatments. And endoresection is now offered here in the United States. Dr. D'Amato we'll be hearing from soon. It's a technique that we're looking forward to hearing more about. Phase 3, recovery. Okay. This is just right after surgery. Those first, I like to think about 3 months. You're recovering from the treatment. You know, the focus is still on the healing of from the surgery. For example, vision issues are pretty important. We're looking then at, can we help recover your vision? Oftentimes people have double vision for a little while. So this is really the focus is still, consider this short term. Again, we're in a long-term project with you guys. So these first 3 phases go fairly quickly, and then you end up in the 4th phase, which is what I call prognosis. And this is really where there's a lot of questions. And the question is, what do you do now? You're recovered, you've adjusted to the new you, if you will. You may have lost an eye, you're probably back at work doing normal activities. And this is where we have some information, perhaps from the tumor itself, the size and location of it. Perhaps there was some material from a biopsy. And also, as there's going to be a lot of talk later, genetic information if you've had a biopsy. How many people here had a biopsy of their tumor? That's about, I'm guessing maybe just about half of you. How many did not have a biopsy of the tumor? Okay, good. That's the other half. The biopsy is an interesting thing, and I found that in meetings in the past, people really focus on that. What is my genetic information? And I would just say that there's, after meeting many patients in my own clinic, I found that people sort themselves out. The choice whether or not to have a biopsy is in some ways immaterial. It's your choice, and that's, I guess, my next slide, the decisions. When you make decisions, you know, last I checked, I think we're in America, it's still free choice for your body, your decisions that affect your body. So some people have chosen not to have biopsies, and that's fine. I think as doctors, again, we try and inform you as to what the treatment options are, but I think hopefully none of you feel pressured into any decision making. Oftentimes you have to choose between 2 things you'd rather not, but keep that in mind. So when I'm in the clinic, we like to broker some of this decision making. I'd like to keep 3 principles in mind. And of course, the first one we all think about is life. Is this affecting your life? You know, is this a metastatic disease that can, you know, adversely affect your life? And that's the top priority. So patients will recognize that if you've had your eye removed, the idea was perhaps to limit the spread. Vision's the second order of priority, but it's very important. As ophthalmologists, we like to work on your vision. So that's, even though we may have a difficult situation with respect to the idea of having a cancer that can spread, we still need to focus on the eye, and there's many treatments now that can help stabilize your vision. And so I'm just stating the obvious, I suppose, here, summarizing. Finally, quality of life is the third area when you're trying to decide, should I be enucleated or have a plaque or what have you. That summarizes, it's a sort of a catch-all phrase, but there are other considerations. Are you having pain? Are you having anxiety? Is this going to affect my appearances? These are all important, relevant questions. You know, us tough guys like to think, it doesn't matter what I look like, but it does. Your eye is important. Your appearances are important. As human beings, our eyes are the way we communicate with the world. And if you've had a loss of an eye or vision, if your eye's not straight, these are things that should be addressed and discussed with your physician. One final thing, pain. I was surprised this last year. I had a patient who was treated with radiation 10 years ago, and she came in for her annual visit, and I somehow had a little extra time, and we started talking, and I found out that her eye was actually quite uncomfortable. It was blind, but it was really daily, just very uncomfortable. And we decided, even though she'd had radiation, we decided to go ahead and take that eye out, and she's much happier now. So, you know, this is a broad, there's so many considerations whenever you're meeting face-to-face with your clinician, and we're very busy, and you only have a few minutes. So I hope this was helpful, at least just to summarize. And we will go ahead and move on with the panel discussion next.